Hello, my name is Jim Wood. I serve as Strategic Counsel to the 501c3 Nonpartisan Concerned Actuaries Group, and it's my pleasure to welcome you to this third program in a series of discussions about the need for more informed healthcare decision-making in what we call the American Healthcare Now What series. The first program in the series, called The Context, focused on the proposition that the American healthcare system, as currently configured, could not consistently deliver affordable, quality healthcare equitably when and where needed. The second program took on the proposition that there is an operational disconnect between the coverage and benefits being promised and the ability of the budgets, infrastructure, and managerial oversight available to deliver on what's been promised. In that broadcast, the distinguished participants concluded their discussion with the observation that the symptoms noted were driven by a serious lack of alignment between needs and resources.
If you look closely at the design of our health programs, and that goes from Medicare to Medicaid to the exclusion for or the tax subsidy for employer-provided insurance, they're all open-ended. And they all, in some sense or another, give the power of appropriations, not to the Congress, but to the public, particular providers who then bargain with their consumers over what additional goods and services to provide, and often setting the price. And that doesn't work politically to have that type of incentive in place. But in terms of cost, it means that the cost of healthcare has been rising really forever for the last 30, 40 years faster than GDP. Now, when healthcare was 2% of GDP, it didn't matter a lot. But healthcare costs are now about 18% of GDP, about 23% of personal income for households. The average cost of a policy for a 4-person family is about $28,000. Total health spending per person in the United States is about $12,000. And yet we come out with statements like, well, people can't afford more than a couple $1,000s of insurance. Well, if we're spending 12, but we can't afford more than 2, or we can't afford more than 10% of our income, but we're spending 23, something's out of whack.
Our third program takes a look at why holistic analysis is important, how it works, and how it can help decision makers and consumers. Our distinguished discussion leaders include Fred Kilborn, FSA, FCAS, independent actuary with the Kilborn Company, and a member of the healthcare team for the Concerned Actuaries Group. Gail Brecky, FSA, is pursuing her PhD in health policy and management at the University of Kansas Medical Center. Mark Little, FSA, Milliman Principal, retired, and our health team leader at the Concerned Actuary Group. And Dr. Tim Bartholow, Vice President and Chief Medical Officer, WEA Health Tradition Health Plans. The previous two programs dealt with the general context in which the system is operating and then looked at the disconnects in the system, so revenue not matching expenses and on across the board. I'd like to start there, if it's all right with you, but there has to be a question about management. So how does management fit into all of this in terms of, as we ask the question, the importance of the holistic analysis, how do people manage the system as it stands now if they don't already have the information they need?
I think that one thing that comes to my mind is management, to me, speaks to things like CMS, managing Medicare, and the Affordable Care Act is an effort to manage the individual market differently than it has in the past. And both of these, to me, are examples of ways in which we are not looking at things holistically. We are not looking at all the relevant information. We're not trying to understand the interactions in all the different areas. Things like the Centers for Medicare and Medicaid Services, which is sometimes referred to just as CMS, they have a lot of emphasis on trying to cut costs and looking at what hospitals are doing with Medicare patients. And so they have had a focus on hospital readmissions, and they put in reporting and penalties associated with that as part of the Affordable Care Act. And there are studies now showing that there are negative impacts to mortality. So this is just an example in my mind of where holistic analysis is needed to understand and do a better job of thinking about and measuring and understanding these interconnectivities between how a hospital is behaving in response to a new program that has penalties with 30-day readmissions, and how the hospital is going to take care of patients, and what the consequences could be downstream for mortality.
The government's focus has generally been on trying to provide extra subsidies to people so that they get coverage and somehow can afford the cost. But that focus has created a tremendous disconnect in the system, because as they keep providing subsidies, they haven't been very diligent in determining which people need it and which people don't. And so we ended up with many people that are uninsured and underinsured, and as many or more who are overinsured. And both of those create terrific problems for the system.
It seems to me in the delivery system that management has an opportunity to understand where we can actually avoid illnesses, have an opportunity to try to coordinate care in a more comprehensive way. And we would like to see management be able to identify the opportunities to not have untoward events, things that are very, very expensive, and by the way, cause human tragedy in the care of patients. And I think amongst the system improvements that could be made, management's eye on avoiding harm and optimizing coordination.
I've been studying the Medicare trustees' reports for over 50 years, each year seeing that there are new things that are provided. But what I've noticed substantially is that the CMS in managing Medicare, which are dealing with numbers that are becoming more and more inadequate for the purpose, so that the management is looking at it holistically, because evaluating, say, Medicare on its own brings inadequate answers that are not really tethered to reality.
Like all of you, I've enjoyed knowing people who are in the provider business and people who are in the government regulatory business, et cetera. These are not bad people. And I think they're trying to get good results out of the system. I'm not sure this is the right question, but I think I have to ask it. How do we get to a point where people with major responsibilities for human lives and literally billions of dollars seem to be utilizing a management model that is more focused on the relationship between the provider and the insurer or the government payer than it is on the outcomes of the health of the United citizens of the country? Is that an unfair concern? Yeah.
I think that's a very valid concern. There's also the relationship between CMS and the public at large, including future generations, which needs to be taken into account.
Yeah, so important questions, right? In my view, there are various attachment points where, for instance, a provider system may well be paid more in a fee-for-service system for having somebody experience unintentionally, right? But they may well be paid more for rescuing somebody from an infection than we are rewarded for having somebody avoid that infection to begin with. And nobody, as you pointed out, Jim, nobody wants any neighbor or patient, right, to have an infection. But management requires, right, having the investments through time in order to assure the greatest safety possible. And that means that there are information technology needs. There are other clinician time requirements in order to put such systems in place.
Is it fair to say that part of what we think is part of the problem, is that because the system is not wired together holistically, two things happen. One is we don't recognize value every time we're engaged in a particular activity. And we don't also recognize risk when we're engaged in an activity. Yeah,
If you take the term value, this is a really a critical thing, is what is value? And in a narrow sense, we can look at it from the standpoint of what's the health status of the person, how able are they access to treatment. We can look at it as cost. We can look at it as economic implications, but really we need to look at all those things at the same time, and we're not doing that. In private systems, very often they're going to be focused, if it's a hospital, on what they can deliver. CMS is going to be focused on Medicare and Medicaid, but those are only part of the system. And when you start enacting provisions on those parts of the system, they have very often various consequences in other parts, and sometimes very serious unintended consequences. And we're not doing that. So in our modeling using the CA2M, what we say is to look at value, you have to look at all the elements. You have to look at cost. You have to look at coverage. You have to look at the access to the treatment, which means the supply of providers and medicines. You have to look at health status. You have to look at economic implications, and you have to look at the long-term sustainability of these items. And if you don't do that and get the data, then you're going to have problems. If you only focus on one or two, you can produce great results in one or two places and very poor results elsewhere.
I would like to chime in here, if I could, Jim, on your question of whether healthcare and the pieces of healthcare are not wired together enough. My take on it, and I do most of my research on primary care, is I think we have gotten to the point where we look at all care, from primary care to hospitalization and downstream urgent care and all of that, as being very much the same sort of thing. And I think as actuaries, we know that insurable events are an important concept in insurance, and something like primary care is akin to changing the furnace filters on your house and, you know, maintaining your car with oil changes. And so from an actuarial and insurance point of view, primary care is a very different thing than, say, surgery or hospitalization. So I think from that standpoint, we have things too closely connected. We're trying to put everything in the healthcare system under a single banner, and we're not paying attention to the nuances, whether it relates to insurance and insurable risk, or whether it just relates to characteristics of the care. We're looking at it too closely together. And I think a consequence of that goes to your example, Jim, of patients having so many prescriptions and it's not really the right thing for the patient, but nobody is looking at that. The accountability sort of goes out the window when you look at everything as being the same importance. Whereas if we would pay more attention to the nuances of how primary care is different than downstream care, and we were able and open to the idea of perhaps letting and encouraging primary care providers and patients to work directly together without insurance in the middle, then there would be a lot more accountability with that sort of fiduciary trust relationship between the doctor and the patient. And you would not have patients with 20 prescriptions that they don't need to be on. So in my view, that sort of nuance of the differences between primary care and downstream care is the sort of thing that we can get to with the holistic view of the system, like is offered by our model and our way of looking at it, to focus on the interconnectivities and the details of what's really happening.
when we talk about holistic analysis, we are not talking about some sort of intellectual exercise. We are talking about a methodology and a mechanism that enable us to empower better decisions and in turn to produce then better outcomes. But in order for that methodology to take place effectively and do those two things, it has to be linked to the healthcare system at a series of different intersections. And so we have been talking about the management role. Well, that's an evaluation and adjustment process, okay? And so when we talk about holistic analysis, it needs to touch, has to be available to, accessible to that evaluation and adjustment mechanism. It is about designing and passing legislation that affects that system. And so this holistic analysis is of little use if we can't figure out how it connects there. And what the Concerned Actuary group has done, as you know, has developed a tool called the Comparative Actuarial Analysis Model that has the capacity to provide holistic analysis in real time at each of those intersections. And I'm going to ask Mark to kind of give all of us a brief backgrounder here, is to help people understand when we talk about holistic, how do you get from a big fancy word to a model? How do you say, well, this is important, this isn't important, or this is the category that we need?
The way we get to this model is we actually look backwards at the actual experience all the way back to 1950. So we developed models for 1950 and 1992 and 2008 and 2017 and 2019. So you're trying to link all these items by looking backwards as to historically what happens, what's the credibility of the data, and then you use those to make projections as the system changes to reflect new system versus old system. So for example, if you change your coverage and you make it richer, what happens to utilization of services by the people? If you cut reimbursements to providers, as CMS often does in the programs to try to save money, what happens to the utilization of services? What happens to the number of providers that exist in those programs? If you create options in the exchanges, how do people change their behavior? How does this affect their health status if they don't have sufficient coverage or if they have too much coverage? So all of these items, and then what happens to productivity if people's health status is poor in the economy?
Just to put our work in context, the data, personal observation, and common sense all tell us that the current healthcare system is not financially stable, not able to deliver quality care equitably, and as one of the top electoral issues for more than 20 years, has demonstrated time and again that it is not politically stable either. The data also makes pretty clear that the current policy-making decision process is narrowly focused on cost and coverage, while essentially ignoring the vast reach and complexity of the whole system. And it tends to be more political than analytical. In 2017, the Concerned Actuaries were focused on sustainability and access, but the data eventually drove us to take a much harder look at how the system design problem did and did not contribute to the challenges and opportunities, which is when we realized that fixing the system requires significantly strengthening the policy decision-making process responsible for the system. More specifically, we need a decision-making process structured around a considerably broader understanding of the totality of the system, with the ability to determine complex interaction within the system, and capable of more fully informing decision makers in real time. The analytical tool we have developed is a comparative actuarial assessment model that addresses all of these needs. The CA2M contains market impact signal areas that capture activity, stimulation, and stress in each of 6 areas, including cost, coverage, access, health status, economy, and sustainability. It also contains coverage delivery mechanisms that capture activity, stimulation, and stress within each of the existing delivery mechanisms, including large group, small group, individual, Medicaid acute, Medicaid disabled, uninsured, Medicare, and other. Cross-referencing the market impact signals against the coverage delivery mechanisms produces 48 intersections, which allow for significantly more holistic analysis of the potential impact of proposed changes to the healthcare system. At every intersection in the grid, the model generates a plus or minus score, indicating whether the action being proposed would positively or negatively affect outcomes at that particular intersection. The question I would have from an audience point of view is, in each of those market signals, what you're telling me is that you've looked at previous experience, looked for correlations in broad categories like enrichment, how rich are the benefits, or measurable changes, right? And then measured that against outcomes. So we got a word like cost. How do you distinguish between cost and price? And we have a category called coverage. How do you distinguish between private sector coverage, insurance, in a traditional insurance model, and a government program that's got very little to do with risk pooling, et cetera? How does the model adjust or think? How do you think about that?
The model splits the markets into various segments. So the private market split into individual coverages, small group, large group, individual split into exchange, non-exchange business, and so forth. The government programs for Medicaid are split between what's called TANF for acute and disabled, which can be disabled, people or long-term care people, and uninsured, and so forth. And there's Medicare separately. So it splits those. And then, of course, each of those programs has very different provisions included in them, from reimbursements to availability of care, as Tim, Gail, and Fred have talked about. And so the algorithms used are very different. And in terms of premium and cost, premiums are what people pay out of their own pockets, or their employer pays to some degree. And so it looks at those choices versus the cost. So if people are selecting a coverage and you greatly subsidize their premium, there's going to be many more people that buy the coverage. But the problem can be is if there's too much subsidy, they'll buy very rich coverage because somebody else is paying for it. So the model looks at all these provisions. And in terms of government programs, that there's very little cost sharing, which there's none on Medicaid, there's limited amounts on Medicare. It looks at that, but it also looks at all the choices that people, whether they're consumers or providers or insurers, have to make, and how that changes the process. So you can get these spirals creating where one market gets very low prices, a lot of people come in, and then another market loses a lot of people and has to spread their costs, and it may cause their market to go into a rate spiral. So that's all those things are covered in our algorithms or factors that try to project what will happen when you make changes to the system.
So I'm going to make a leap here and ask all of you to stay with me as I do it. Okay. So I'm going to say to Mark, well, okay, so let's put the model, the matrix. It's really a matrix that runs the delivery market pieces against the market signals that you've talked about. And when we look at that grid, we're looking at 48 intersections. And that's an amazing complexity, okay? Most decisions that I can see going on around the country about healthcare take place around cost and coverage, and it's a debate about who you are and what bumper sticker you got on your car too often. But as you can tell when Mark starts to describe it, it is like diving into the middle of these 48 intersections. It is so dense and so interrelated and so interconnected that it's very hard to get your arms around when you try to describe it, even when I put that grid in front of you. So what I would like you to do, if you would, Tim and Gail and Fred, is to take an example of something that frustrates you with the current system or something that pleases you with the current system, and explain it to Mark and ask him how the CA2M would make a difference in that particular circumstance, or where he thinks the grid would light up and provide information to you that you're not currently getting.
So I'll jump in. Mark, I'm hunting how it is that the strategy of cost shifting, right? Some folks will say public reimbursements are too low and commercial has to make up the shortfall, right? but it's not helped us bring a comprehensive discipline to the market. And yet I'm watching programs like in Medicare, the end-stage renal disease and the kidney transplant programs actually perform extraordinarily. I'm sure there are improvements to be made, but there are these segments, frankly, of great hope and examples of how we've been successful. Do you think your model could identify those places where the system actually is working well, and some of these other places in healthcare delivery that could learn from some of these important examples?
Tim, I'd say the answer is yes. We could make the system much better if we can figure out how to get that utilization in line with the needs of those people. And that's one of the things I think the model could do in a whole bunch of areas that you've talked about. But keep in mind that when you get down to things like transplants and various conditions under, let's say ICD-10 codes, you need to get more cells in the model to split out those people. And so our model really, we think, is really only at a stage 2 or 3. If we think it still has a long way to go, but the concept is that you're correct.
So Mark, I would say that the area where my mind goes in terms of this question about using the model and how the model could help us do a better job than perhaps we've been doing is just the Affordable Care Act. So even with the improvements and more targeted subsidies that were put in place in the previous administration, we're still only about 35% of the enrollment that was expected. Yet it's very expensive. So just to put some numbers to it, the individual market now has about 2 million more people than it did pre-ACA, and the subsidies that pay for the coverage for those folks, $50 billion. So we see that we have done a poor job, perhaps in the design of ACA or perhaps in the subsequent enhancements and modifications. I think we've done a really poor job of figuring out and understanding what will happen when we offer these subsidies to people with their complicated formulas based on income and age, how people will actually respond. And again, we're only about a third of the enrollment that it really needs to be a stable individual market over time. And it just strikes me that this is a place where a model like the Concerned Actuaries model would do a great job of modeling out all these interactions and get us to a better understanding of what could come about from this legislation, or perhaps better legislation in the first place.
Actually did do a beta test on that. And so CBO projected that the market would show rate increases above healthcare trend of 13% or so. And our model said it would be, I think, between 55 and 60%. And as I recall, the actual experience is showing closer to 60%. So why did that happen? It's pretty simple. So we created a lot of subsidies, but we created coverage for people regardless of their health status, coverage pre-existing conditions. We also put community rating in so that companies were not able to charge per age. So what happens when you do those types of things, you effectively create an incentive for people in poor health and older people to join, because they're being subsidized to a much greater extent than younger and healthier people. So effectively, we created what we call a high risk pool for these people. And if you look at the health status of the population in the exchanges, it's very poor compared to what's in the rest of the individual market or small group or large group. And that's why they violated basic actuarial and some other principles as well. And so that created some very serious unintended consequences.
We know that it costs about $500 to $700 to produce an MRI in America. Maybe it's a little different by geography, but it's about that. And yet I think in the commercial marketplace, we'll often see rates between $1,500 and maybe even $3,000, right? If we could, for commodities like, at least the technical portion of imaging or laboratory or even to some extent drugs, right? If we could have the dollars that are in our system being used in payments that are probably higher than commodity, and redeploy the savings to the better decision making by our clinical delivery system. Does your model can it guide us toward that opportunity, do you think?
I believe it can. Models only work as a tool, so you have to be able to do some testing to determine what moves the needle in the right direction versus the wrong direction. You're absolutely right. There's tremendous amount of waste and overcharging, but if you go back historically, why has that occurred? And I think the reason is, when we go back and look at the earlier models, the level of discounting in the healthcare system has changed dramatically since the early 90s. It used to be Medicare payments or reimbursements were probably in the 1990 around 90% of charges, and now they're probably closer to 35%. So, and Medicaid's lower than that. And so we've got a system where there's virtually little transparency. In fact, if I recall, the current administration, it might have been even under Trump, was trying to get hospitals to be transparent with their cost and their charge levels and all that. And it's not working very well. And the reason is that the hospitals in many cases are charging, $10 or $20 for an aspirin, let alone things you're talking about. And why are they doing that? Because it's not right, but they've been forced into these very strange cost, value relationships, because we put so many people into Medicare and Medicaid with these low reimbursements as well as uninsured, that we've just created a tremendous disconnect in the system. And so now we have to rejigger that. And it's not just about fixing the reimbursements. We have to change the whole delivery and mix that with the financing to get the change. It's sort of like trying to lift price controls, which effectively they sort of are, even though they don't call them that. And to unwind that is extremely difficult. So the model can lead us in that direction, but it would take a lot of work and a lot of involvement of experts from various parts of the system to.
The issue here is helping people understand what it is we are trying to put on the table. And I go back to the idea that this is ultimately about helping people make better decisions. Okay, it is about legislators making better decisions. It is about providers making better decisions. It's about managers making better decisions. But it's also about consumers making better decisions. And Mark, I'll let you start again here. I'm trying to figure out how we help people understand what your model does. So come out from inside the box, if you would, and now do what I asked Tim and Fred and Gail to do, and give us a couple of examples.
Yeah, it's really about, which I think Tim pointed out, it's really about efficiency. It's just that it's about efficiency across delivery. It's about efficiency across financing, and the interlocking between those two, because they're very interdependent. So you have to try to get much better efficiencies. We are wasting a lot of money and a lot of resources, and when that happens, people in other areas suffer. If we give too much subsidy to people, that by itself wastes it, but too much subsidy, we know from experience, creates overuse, overtreatment, which doesn't improve health status nor productivity, and generally leads to fraud and abuse. Too little subsidy puts people in untenable positions that they can't get the treatment. They don't have the opportunities to be productive that other people do. So there's a loss of value in really both of those instances. And so this is really about efficiency and the interlocking aspects, as Gail talked about, and then the long-term ramifications on future generations that Fred talked about. So it's all interdependent. If you start separating it out, you might be able to solve one problem, but you generally are going to just push the can down the road or kick it down the road, as they say, and create other problems elsewhere.
So how can we possibly, without a model, fix the problem that year on year, nay, decade on decade, we've had this increase in healthcare cost, so much so that we have a healthcare cost of living, as it were, right? And yet wages are only going up at 2% or something less. Will you all help me understand, without some set of tools, including a model, how do we not run into a wall at some point in time? And I realize we've argued this for 20 or 30 years now, but it cannot be that sustained additional investments and trend into healthcare that exceed wage can possibly allow us success. Somebody help me, please.